In the coming years, we are going to continue to see the development and FDA approval of a lot of novel targeted drugs for patients with relapsed large cell lymphoma. And I think specifically a lot of these drugs are being developed for patients that are failing a transplant or ineligible for a transplant, or we cannot get into a remission with salvage chemotherapy. I mentioned tafasitamab. I talked a little bit about CAR T cells, polatuzumab. There are several other drugs which are also being developed in this space, which are biologic, and some of them which are targeted drugs. And as we move forward, as these drugs all become available to the clinician, the big thing is going to be, frankly, deciding which of these drugs to use in which patient population. And I think that this decision should be based upon the drug's side effect profile as well as the activity of the drug. In patients, for example, who potentially have compromised organ function, we might not want to use drugs like CAR T cells that could have a really tough effect on their performance status, or drugs that maybe affect heart function, maybe affect kidney function. So in patients who are great performance status and are great candidates, I would probably pick CAR T cell therapy. In patients who potentially are older, have compromised organ function, I might be thinking about a more biologic regimen like tafasitamab plus lenalidomide, or potentially emerging novel biologic regimens. But I think that really it's important to look at the entire profile of the drug, of the combination when you're making these decisions. Again, not only side effects, but also what's the goals of therapy and what's the activity of the combination or the single drug that you're planning on using.